Hello and welcome. If you manage patients with dizziness, this explainer is definitely for you. Today, we're going to tackle one of the most common, but also one of the most frequently missed causes of dizziness. So let's dive right in. Just so you know, this whole explainer is based on the Comprehensive Literature Review, Orthostatic and Medication-Related Dizziness, which was published by Australian Dizziness Clinics. It's really designed specifically for busy clinicians, just like you. And here's why this matters so much. Get this. More than 1 in 5 of your patients who present with chronic dizziness has a treatable orthostatic cause. So, the whole goal of this explainer? It's to show you how to tell which of the 5 distinct syndromes is sitting right in front of you, using a simple bedside test that you can get done in under 10 minutes. Think of this as a bit of a clinical detective journey. First, we're going to look at why this is such an overlooked diagnosis to begin with. Then, we'll examine the body's balancing act, the underlying physiology. After that, we'll meet our 5 main suspects, the syndromes themselves. We'll check out their telltale timelines, and then finally, we'll pull it all together into a diagnostic blueprint you can start using right away.
Dizziness can feel like such a frustrating mystery, not just for the patient, but for us as clinicians too. It's incredibly common, especially in older adults. It can affect over half of those in residential care. But so often, a really key clue is just completely missed.
And the stakes of missing this diagnosis, they are incredibly high. We're not just talking about feeling a little lightheaded here. This is a powerful predictor of falls, of fractures, of cognitive decline, and even mortality. That's why a simple bedside test can literally change the entire trajectory for these patients.
Okay, so to really get what goes wrong, we first need to appreciate the elegant system that keeps us all upright. Let's think of this as understanding the crime scene before we start identifying the culprits.
Now, this diagram here, it just perfectly maps out the body's incredible reflex. The second you stand up, a huge volume of blood, we're talking 500 to 800 milliliters, instantly pools down in your legs. Instantly, these little sensors in your major arteries called baroreceptors, they detect that pressure drop. They fire off signals that kick off a 2-part response. Your blood vessels constrict and your heart speeds up. And the whole goal? It's just to keep a steady flow of blood going to the brain. It's a stunningly fast and coordinated process.
But this elegant system can fail. And there are really 5 key points of breakdown that we need to be looking for. Things like damage to the autonomic nerves, simple volume depletion, certain medications that block the reflex, age-related vascular stiffness, or even an underlying heart problem. These are the root causes we're hunting for.
So how do we get a clue right there at the bedside? Well, it all comes down to one absolutely crucial piece of physiology, the heart rate response. This tells a huge part of the story. If the heart rate barely even budges when they stand, you've got to suspect autonomic failure or maybe a drug like a beta blocker. But if it skyrockets while the blood pressure holds steady, well, that points us toward a completely different diagnosis, POTS.
Okay, so now that we've got the physiology down, it's time to meet our lineup of 5 suspects. These are the distinct clinical syndromes that you'll be able to identify with just a simple stand test.
And this table just brilliantly illustrates all the differences. You've got initial OH, which is a very rapid but really transient drop. Then there's classical OH, the sort of textbook drop that happens within 3 minutes. Delayed OH. Now this one is commonly missed because it only happens after 3 minutes. Then we have neurogenic OH, which is marked by that failed heart rate response we just talked about. And finally, POTS, which is defined by that rapid heart rate without a significant blood pressure drop. And you can see how the management priority for each one is quite different.
Now, I really want to draw your attention to a critical clinical pitfall here. Initial OH and POTS, especially in younger patients, are so often misdiagnosed as anxiety or some kind of functional dizziness. It is absolutely essential to remember these are real, they are measurable, and they are treatable physiological conditions that a proper stand test will unmask.
All right, let's look a little closer at the fingerprints of these syndromes. Each one creates its own unique pattern of blood pressure and heart rate changes over time. And learning to spot these patterns, well, that's the key to a swift diagnosis.
So let's compare the 2 most distinct patterns side by side. With neurogenic OH, you see this profound fall in blood pressure, but the heart rate, it just doesn't respond. It stays flat. With POTS, it's the complete opposite story. The blood pressure is largely preserved, but the heart rate just skyrockets by 30 beats per minute or even more. You see? That heart rate response is the crucial clue.
So, to quickly recap the whole spectrum right here, initial OH is fast and fleeting. Classical is your standard drop within 3 minutes. Delayed OH is the latecomer, really easy to miss. Neurogenic OH is that pressure drop without the heart rate rescue. And POTS is all heart rate with no major pressure drop.
Now, let's put it all together. We're going to consolidate everything we've just covered into a practical, clear diagnostic plan that you can literally take into your clinic and use tomorrow.
Okay, here are the crucial points to take away from all this. First, there are 5 syndromes, right? And you tell them apart by the timing of the BP fall and the pattern of the heart rate response. Second, if that heart rate rise is blunted but there's a big BP drop, you're thinking neurogenic OH. If it's exaggerated with a stable BP, think POTS. And third, and this is probably the most practice-changing point, a single 1-minute reading is just not enough. You will absolutely miss both initial and delayed OH. You have to measure at 1, 3, 5, and 10 minutes.
And here it is, the entire diagnostic pathway in a single flowchart. Let's just trace it for a second. You start with the active stand test. If you see a big drop in blood pressure, the next question is all about timing. Does it happen in under 30 seconds, between 1 and 3 minutes, or only after 3 minutes? That timing points you to initial, classical, or delayed OH. From there, you just assess the heart rate response to distinguish between neurogenic OH and POTS. This map really gives you a clear, systematic path from symptoms right to diagnosis.
So I'll leave you with this final thought. As you think about your patient list for the coming week, just ask yourself, which of your patients with that unexplained dizziness, those falls, or that nagging fatigue could benefit from this simple 10-minute test?
Please join me in our next explainer. We're going to break down the active stand test protocol and that really high-yield medication review in much greater detail.
To explore more topics on dizziness, vertigo, and imbalance, and to get access to a ton of great clinician and patient materials, please visit AustralianDizzinessClinics.com. And hey, if you found this useful, please subscribe and share it with your colleagues. Thanks for watching.